Hi everyone, my name is Amog Karnik, and today we're going to be talking about diabetes, and specifically talking about the pathology, physiology, and a little bit of the pharmacology related to diabetes and each of its different subtypes. So our learning objectives, the first is to talk about the roles of insulin and ADH with respect to the major functions of the kidneys. The second is to talk about the filtration system a little bit of the kidneys as it relates to diabetes mellitus. The third is to talk about the urinary concentration and dilution systems and how it relates to diabetes insipidus. And the fourth is to talk about the distinguishing between diabetes mellitus and insipidus based on their pathophysiology. And finally, to evaluate some of the treatment options that are available for each subtype of diabetes. So diabetes, what does it actually mean? So it comes from the Greek and Latin roots to essentially go through. So diabetes is a condition in which urine goes through the body. And we'll find that each of the different types of diabetes, whether it's type 1 diabetes mellitus, type 2 diabetes mellitus, central diabetes insipidus, or nephrogenic diabetes insipidus, they're all characterized by excessive urination, and sometimes the content of that urine is going to be a little bit different, but the major clinical finding is polyuria, or excessive urination. So who are some of the major players involved in these disease processes? So the first is the kidneys, and we'll talk a little bit about the major functions of the kidneys. The second is glucose, and glucose is our major energy source, and it plays an important role in the pathogenesis of diabetes mellitus. Insulin is a hormone that regulates glucose levels, and it's made by beta cells in the pancreas. And ADH is a hormone made by the pituitary gland. Then instead of regulating glucose, it regulates water balance, and specifically water reabsorption in the kidneys collecting duct. So the kidneys. There are two major functions, and it's kind of simplified a little bit. The first of which is to filter and reabsorb solutes to and from the blood. And we'll go into a little bit of a schematic later on when we're talking about what filtering actually means, and then reabsorption and also secretion that eventually leads to what is known as urine and that's excreted from the body. The second major function is to concentrate the urine and balance water volume throughout the body. And this is an extremely important function of the kidney because it allows us to be in homeostasis. We know that we need to be in a certain homeostatic level for water, since water comprises so much of our bodies, and the kidney's role in reabsorbing or letting water go plays a critical role in the pathogenesis and also the treatment of all the subtypes of diabetes. So let's delve a little bit deeper into the filtration and reabsorption system of the kidney. Now you may recognize this figure from other textbooks, but it's a nice schematic that kind of depicts this relatively complex process in a very simple fashion. So here we've got our capillary, our glomerulocapillary, and the capillary has holes or fenestrae that allow it to transmit solutes that are kind of floating around in the blood, and they get filtered through the capillary wall into something called Bowman space. And the Bowman space is the beginning of the renal tubular system, and it's where all of those solutes essentially start their journey into either going back into the blood or becoming part of the urine. So once they're filtered, they can be either reabsorbed, so go back into the bloodstream through this epithelium that lines the renal tubular system, or they can go the other way. Additional solutes can be secreted from the bloodstream into the tubular system here, and eventually all the solutes that remain are excreted in the urine, and they leave the body permanently. So a lot of the solutes that we're talking about here, sodium, potassium, urea, glucose, all of them have unique profiles in terms of filtration, reabsorption, secretion, and eventually excretion. So there are some solutes that we really want to keep in the bloodstream, and so they're excessively reabsorbed. There are some solutes that we want to secrete and get rid of, and they're excreted in the urine almost all the time. And there's some solutes that kind of fall in the middle, where some is reabsorbed, some is secreted, and the amount that's excreted varies depending on a lot of other factors. And glucose happens to be one of those factors. So first off, where is our glucose actually coming from? So we know it comes from food, and food is broken down into glucose by digestive enzymes in the mouth, in the stomach, and eventually is broken down into simple sugars, into glucose, fructose, and they're absorbed into the blood in the intestines. And this is the first sort of gateway from the GI tract into the bloodstream, and then from the bloodstream, the glucose can travel all throughout the rest of the body, where it can eventually be used by cells to produce energy and ATP. And we're all familiar with glycolysis and oxidative phosphorylation, and that process all relies on glucose. So it's really, really important for those cells to be able to survive, to have access to glucose. But glucose can't just enter cells by itself. It can't just walk into a cell and say, hey, I'm ready to go. Essentially what it needs is the help of insulin, and insulin would play the role of a key, going into a door, unlocking it, and allowing the glucose to go into the room. And so insulin is critical in allowing glucose to be taken up by peripheral cells to be used for energy. Another important thing to note when we're talking about just general glucose metabolism is that not all glucose from a meal, not all glucose from the sandwich I ate for lunch today has been taken up and used for energy right away. It can be taken up by the liver and be stored as a polysaccharide known as glycogen, which I'm sure you're all familiar with. It can also be used to assist in the process of protein synthesis in muscle tissue, to build proteins. And it can also be used to produce fats and stored as triglycerides in adipose tissue. So there's a lot of different ways that glucose can be used, but essentially it's our main energy source. So when we have too much of it, we take it up and we store it away. We put it in a storage unit in different forms, and eventually we'll be able to unlock it when the time comes. So after glucose is essentially absorbed from the intestines into the bloodstream, it can travel all around, all to the brain, to the arms, the legs, back to the stomach, essentially supplying those organs and those tissues with the opportunity to be using it for energy. But a lot of that glucose, like I said, is not always taken up right away, and it needs to travel. And one of the places that it can travel and be eventually stored, one of the gateways to that is the kidney. And we talked about a little bit before of filtration, reabsorption, and secretion. So we don't want to excrete a lot of glucose because, again, glucose is our major source of energy. So glucose is actually exclusively reabsorbed in the kidneys at the point of the proximal tubule, and it's done via co-transport with sodium ions. But unfortunately, the renal tubular system isn't lined with all of these co-transporters. There's only a limited number of them. So there's a concentration of glucose in the blood at which no more glucose can be reabsorbed back into the bloodstream. And at that point, that glucose starts to collect in the renal tubular system and is eventually excreted in the urine. And we'll talk a little bit about this later on, but this is the major sort of pathogenic event that leads to, one, glucose in the urine, and two, increased urine volume, because the presence of glucose in the urine draws water into the tubular space and increases urine volume and eventually leads to polyuria, or excessive urination. So hormonal regulation, like we talked about before. Glucose can't enter those cells without the help of insulin. They can't leave the bloodstream and go into a cell without insulin. But glucose also can't be, the glucose that cannot be reabsorbed over a certain maximum concentration is excreted in the urine. So you can see here that without insulin, we've got a problem here, because we've got a lot of glucose collecting up in the blood, and then eventually it gets reabsorbed back into the blood. But if it can't, now we've got more and more glucose accumulating in the urine. And as I've stated on the slide here, more glucose in the urine increases osmotic pressure, so it draws the pressure that it basically allows water to enter that renal tubular space and increases urine volume significantly. So if insulin's not working correctly, we have the problem of essentially too much glucose in the blood, too much glucose in the urine, and eventually too much urine. And that's what leads to the process of polyuria in diabetes mellitus. So briefly on insulin and then its sister glucagon. Insulin is secreted by pancreatic beta cells, and they're found in these islets, these pancreatic islets. And the role of insulin, again, is to increase glucose uptake. It helps the insulin get back into those cells. It also facilitates storage of glucose as glycogen. It facilitates protein synthesis in the muscle tissue, and it also facilitates fat storage in adipose tissue. Glucagon, on the other hand, is the opposite. It does the opposite of insulin. So it's secreted by alpha cells, which are also found in these islets. And it, as our biochem professor, Dr. Zering, would say, glucagon shows up when glucose is gone. So it opposes insulin by increasing blood glucose levels, by breaking down glycogen from the liver, breaking down fats from adipose tissue, and increases the availability of glucose to be used in the bloodstream. So the balance between these two hormones is really important because we all have basal levels of insulin and glucagon, but after a meal, we're going to have more insulin than glucagon because we have more glucose that's available and wants to go in. And after we eat breakfast and we don't eat, let's say we don't eat lunch until 2:30 p.m., then we're going to have low levels of insulin, we're going to have high levels of glucagon, and that's going to lead to more glycogen breakdown, more fat breakdown. And that's going to be really important later on when we talk about some of the complications of diabetes when this hormonal system is thrown into imbalance. So we're going to take a step back here and talk about, we just talked about filtration, reabsorption, and as it related to glucose, and now we're going to talk about the reabsorption and concentration of urine related to water reabsorption and water concentration. Now we know that water balance is really important. We've all been dehydrated, and we've noticed that, we just seem to operate a little bit slower, everything's not working as well, and that's because we just simply don't have enough water. When we're in a state of water deprivation, so on the left-hand side here, basically what's happening is we have the same amount of solutes, nothing's really changing in our blood concentration, but we don't have enough water to support that fluid, to support those solutes. So we know that osmolarity is a measure of solute content over total volume. So if we have water deprivation, our total volume is decreasing, so plasma osmolarity increases. So what does our kidney want to do in the case of water deprivation? Our kidney wants to say, you know what, I don't want to give up all this water. I want to hold on to as much as I can. So it increases as much water reabsorption as possible, and that results in an increased urine osmolality. So there's less water now in the urine because more water is being reabsorbed back into the blood. And so that gives us our urine is a little bit darker, and that's really because there's not as much water in there to dilute all of the solutes that are being excreted. So in the case of water deprivation, we have more concentrated urine because we're holding on to as much water as we can into the bloodstream because we don't have a lot of water to work with. Now conversely, on the other side, if we're drinking too much water, like 4 or 5, 6 glasses more at every meal, so you're drinking 15, 16 glasses of water, the recommended amount I think is 8 glasses of water a day. So if you're drinking way too much water, now our body fluids the volume has increased, which means the plasma osmolarity, so the concentration of solutes with respect to total blood volume, is now way lower because our total blood volume is way higher. So this is going to tell our kidneys to say, you know what, we can afford to get rid of this water because we have lots of it floating around in our blood. So we're going to increase water reabsorption, which means that we're going to decrease water reabsorption, which means we're going to increase water content in the urine. So our urine is going to be much more pale, it's going to be dilute, and there's going to be a lot of it because there's a lot of water that's being excreted from our body that we just don't want to hold on to anymore. So we're just going to give it up, and it's going to show up in the urine. Now, how do we actually regulate this process? Because it seems kind of, it is complex. It doesn't just seem complex, it is complex. And the major player in this entire process is something called antidiuretic hormone, which again is produced in the posterior pituitary gland. So our hypothalamus can sense when we have too much water or too little water, and there's a whole system in which the hypothalamus is able to do that. And it tells the pituitary to say, hey, we need you to secrete ADH. ADH increases water permeability in the distal convoluted tubule, so at the end of the renal collecting system, and promotes water reabsorption. So it promotes our holding on to water, and thus it increases the concentration of solutes in the urine, so it darkens our urine, if you want to think of it that way. So in the case of water deprivation, like we talked about before, we're going to have increased levels of ADH because it's going to tell us, hey, we want to increase our water reabsorption. In cases of water consumption, we have too much water in our bodies. Our hypothalamus is going to say, hey, you know what, posterior pituitary, you don't have to secrete ADH anymore because we've got plenty of water that we've got to hold on to. So ADH levels will decrease, and that will tell the distal convoluted tubule and collecting duct not to collect as much water anymore, and we'll be able to excrete that water and thus decrease our urine osmolality because we've got a lot more water being excreted, and it's going to be very, very dilute. Okay, and here's just the signal transduction pathway for ADH. It is complicated, and it's a little bit beyond the scope of our discussion right now, but it's important to note that essentially what ADH does is it goes into the from the blood, it goes into these epithelial cells in the renal tubular system, and it says, I want to promote water transport here. So it actually upregulates something called an aquaporin, which is a water channel, aquaporin, in the luminal membrane here, and it basically allows water to go from the lumen, so from the urinary space, back into the cell where it can go back into the blood. So now let's talk a little bit about disease. So we talked a lot about physiology, a lot about renal physiology, and a little bit of endocrine too. So what about the actual pathology and pharmacology? So the first disease we're going to talk about here is diabetes mellitus. And there's two types of diabetes mellitus, type 1 and type 2, and we'll go into the details. But the basic disease process here is that we've got hyperglycemia. We have high levels of glucose that eventually can't be handled by the kidneys and eventually ends up in the urine that draws water into the urinary space and increases urinary output. Okay? So, type 1. Type 1 is due to an autoimmune destruction of pancreatic B cells, beta cells, by T lymphocytes. So, we know that the beta cells make insulin. So, if we have an autoimmune destruction of those cells, we're not going to be able to produce any insulin. So the clinical findings, high serum glucose. Now that makes sense because insulin is needed for glucose to go from the serum back into the tissues to be used for energy. Other clinical findings, weight loss, low muscle mass. And this is because we don't have insulin, so we don't have the opposing action that it has on glucagon. Now we know glucagon takes glycogen, breaks down proteins, it breaks down fat, it basically makes energy sources available. And so weight loss, low muscle mass are all effects of increased glucagon that is not being opposed by insulin. So the weight loss and low muscle mass are really key findings that tell you that, hey, we're not making enough insulin because not only are we not taking up glucose, but we're also not opposing the actions of glucagon. The final sort of major clinical findings are the polyuria, polydipsia, and glycosuria. Now, polyuria means poly, lots of urine. Polydipsia means that you have excessive thirst, and that makes sense. If you're producing lots of urine and you're losing a lot of water, your hypothalamus is going to tell you that you're really thirsty, so you're going to be thirsty. And glycosuria, you can tell what it means. There's glucose in the urine, and that's because we have so much glucose in the blood that it goes into the urinary space and it gets excreted. And we've talked about this ad nauseum at this point. If you did a biopsy of the pancreas in a type 1 diabetic, and I'm not really sure how common that is to do, but if you were to do it, this is what you would see. This is an islet right here, and you see these dark blue cells. These are lymphocytes. So these are the T cells that are going in and actually destroying those pancreatic beta cells in the islets. So if you were to do a biopsy, this is what you would find. Now, the most serious complication of type 1 diabetes is something called diabetic ketoacidosis. And diabetic ketoacidosis comes from the idea that if we don't have any insulin, we have unopposed levels of glucagon. And as we talked about before, glucagon basically takes stored energy and breaks it down so that we can use it right away. The major culprit in diabetic ketoacidosis is the breakdown of lipids and stored fats into free fatty acids. And free fatty acids are then taken from the serum into the liver, where the liver says, hey, you know what, I can convert this fatty acid into something called a ketone body, which can then be used as an energy source. So we have no insulin, we have unopposed glucagon, we have fatty breakdown that leads to ketone body production by the liver that is then used as the primary energy source instead of glucose in these patients. So some of the clinical findings that we're talking about are obviously excessive serum ketones, and ketones actually decrease the blood pH. They're acidic, so they make the blood more acidic, hence the name ketoacidosis. And to kind of compensate for this acidosis, our lungs will respond by these deep sort of labored breaths, and they're called Kussmaul respirations, and they help compensate for the acidosis by basically taking deep breaths and increasing the carbon dioxide content that we have to sort of try and counteract the ketoacidosis. It doesn't completely compensate, but it is one of the compensatory mechanisms. Other clinical findings that are associated with diabetic ketoacidosis: dehydration, obviously. We're still urinating too much, so we don't have enough fluids. Nausea and vomiting are also common, and mental status changes. Mental status changes are probably the most salient and probably most visible, and this is because our brain isn't used to using ketone bodies as an energy source. It really prefers to use glucose. So when it starts to use ketone bodies as an energy source, things kind of get a little bit funky, and the brain doesn't work as it normally should. So the manifestation of that clinically is a change in mental status. Patients in DKA often have fruity smelling breath, and this is due to the presence of acetone in their breath. And acetone is one of the ketone bodies that's produced by the liver. It's not really found in the serum simply because of its molecular size, but acetone is one of the things that you can detect on someone's breath, and that is a pretty good indication that they're in DKA. So just something to be aware of. So how do we actually go about treating type 1 diabetes? Obviously, if we don't have any insulin, we want to limit the amount of carbohydrates that we take in through our diet, because we know we can't break down that glucose and use it for energy. So if we want to minimize the sort of dangerous side effects of type 1 diabetes, we want to kind of limit those carbs. In terms of pharmacologic therapy, we need to replace that insulin. The fundamental disease process here is that there's no insulin being produced by the beta cells because the beta cells are being destroyed. So we want to replace insulin in order to have the metabolic effects of insulin that we've talked about here. Now, there's a few different classes of insulins, and Dr. Zarek, I'm sure, has gone into a number of these, but I'm just going to talk about a few examples here that are commonly used clinically and kind of make sense in terms of why you would use them. So after meals, type 1 diabetics often use a rapid-acting agent like aspart, which basically immediately facilitates that uptake of glucose into body tissues. We know that after a meal, you have a high amount of glucose that's in your bloodstream, and so in order to kind of overcome that hyperglycemia postprandially, you use aspart to get rid of that hyperglycemia right away. Stress hyperglycemia is a little bit hard and a little bit kind of difficult to understand conceptually, but essentially what happens is there's a number of hormones that regulate sort of the management of insulin and glucose and its relation to stress. And so if there's a hyperglycemic state due to external conditions and prevents the normal uptake of glucose and the normal metabolism of glucose, you can use regular insulin, so just regular formulated insulin in order to alleviate that. And the key difference here would be like a trauma or an infection or something like that, where it's causing hyperglycemia where it would not normally occur. So it's not expected, It's expected after a meal, but it may not be expected due to a trauma or an infection or something like that. And so for stress hyperglycemia, you would use a regular formulation of insulin. The final drug I have on here is glargine. Glargine is a very, very slow-acting insulin. And essentially what glargine is used for is to achieve basal glucose control in type 1 diabetics. So we're not producing insulin, so instead of rapidly taking up all the glucose immediately after a meal, kind of like a quick fix, glargine is essentially like replacing those basal levels of insulin that we would normally have with a normal pancreas, and helps type 1 diabetics modulate their glucose levels by providing a very, very slow-acting, low level of insulin constantly. Now, side effect-wise, it's important to keep in mind that all of these formulations are insulin, and they do increase glucose uptake. So their major side effect is hypoglycemia. So symptoms of hypoglycemia include lightheadedness, dizziness, obviously low blood sugar, and so it's really important to keep that in mind. And if you are prescribing a patient formulation of insulin, it's important that they know the symptoms of hypoglycemia and they know when they're going to be experiencing that, because type 1 diabetics obviously have this condition for quite a long time. It's an autoimmune condition that's often diagnosed in childhood, so they often know when they're about to go low on sugar and when they know that they're about to go into a hypoglycemic state. So just important to kind of be aware of. So type 2 diabetes, and we're going to move along here and talk about the disease process here, which is fundamentally different than type 1, simply because here we're producing insulin correctly, but instead of binding to its receptors and having the effect that it normally does, which is to increase uptake of glucose by the cells, those cells decide that they don't want to listen to insulin, and so they become resistant. There's a number of different hypotheses related to this. The major one is that obesity really contributes to the development of insulin resistance, and we'll talk about in a little bit how that kind of governs a major treatment strategy for type 2 diabetics. But essentially what happens here is that our tissues are resistant to insulin, and that leads to increased production of insulin by pancreatic beta cells up until the point where they just get exhausted and they can no longer produce insulin. And then that's usually later on in the disease process, but then those patients also need insulin supplementation because they're not producing any more insulin. So type 2 diabetes, insulin resistance. Now, major clinical findings, again, high serum glucose. We've talked about this before. Again, polyuria, polydipsia, and glycosuria. Again, same mechanism we referred to before. There's lots of glucose in the blood, ends up being lots of glucose in the renal tubular system, can't be reabsorbed, eventually pulls water into the renal tubular system and leads to a lot of urine. If you were to do a biopsy on a patient with type 2 diabetes, you would find these pink amyloid deposits here. I realize that the whole slide is pink, but you can see that these deposits they're kind of amorphous and asymmetric. That's a protein called amyloid, and this is very characteristic of a person's pancreatic islet with type 2 diabetes mellitus. Now, one of the key complications of type 2 diabetes is not diabetic ketoacidosis, although it is technically possible. But the most serious complication of type 2 DM is something called hyperosmolar, hyperglycemic state. So we can kind of follow the physiology here and say, okay, if we have lots of blood glucose, we're going to lead to excessive urination, polyuria, and if we don't kind of stay hydrated and if we don't correct that excessive urination as soon as possible, we can actually deplete our stores of body water and body volume due to just continuously urinating. So if we keep on urinating, we're eventually going to deplete our body volume of water. And that body volume is really what regulates our blood pressure. It's really what keeps our blood pressure having enough fluid. So if we're losing a lot of fluid, our blood pressure is going to drop. And when our blood pressure drops, we're at increased risk for going into a coma or even dying. And so it's really, really important to avoid this state because this is probably the most serious thing that can happen to a type 2 diabetic and can eventually lead to death. Now, it's really important to note the difference between a hyperosmolar hyperglycemic state and diabetic ketoacidosis. And the primary difference here is that there are normal ketone levels in this state, in the hyperosmolar hyperglycemic state, as opposed to DKA. And why is that? In DKA, we didn't have enough insulin, so there was lots of unopposed glucagon, which led to ketone body formation from fatty acids being broken down. Here, we have normal levels of insulin, sometimes even increased levels of insulin, but they just can't have the normal effects that they normally do. However, that circulating insulin is still able to inhibit the function of glucagon. So we don't get this unopposed effect of glucagon, which leads to ketone body formation. So it's important to note that the key difference between diabetic ketoacidosis in type 1 and hyperosmolar hypoglycemic state in type 2 is the presence of ketone bodies in type 1 and lack of ketone bodies, or normal ketone bodies, so not excessive in type 2. So how do we treat type 2 diabetics? Obviously, as I referred to before, obesity is a major risk factor. So diet and exercise for weight loss is an extremely important component of treatment for type 2 diabetics. Pharmacologically, there's a number of oral hypoglycemic formulations that are used in combination, sometimes alone, sometimes with other drugs with varying mechanisms of action. And I've grouped them here based on sort of the track of glucose and insulin throughout the body. So it kind of will help you conceptualize them a little bit. And Dr. Zarek, I'm sure, has gone into some of the specific mechanisms of action here. So I'm going to be talking about these drugs a little bit of a higher 20,000 feet level. So we know that when glucose is ingested, when we ingest food and we break it down, the first time that it gets into the bloodstream is in the intestines. So one strategy for reducing high blood glucose levels is to prevent that intestinal absorption in the first place. So drugs like acarbose and miglatol help stop that intestinal absorption initially from getting glucose into the blood. Now, side effects associated with these drugs mainly associated with GI disturbances, and that makes sense because we are basically interfering with the GI tract's ability to get rid of digested products, so you're going to have a little bit of nausea, vomiting, diarrhea, that type of stuff. The second major treatment strategy for type 2 and oral hypoglycemics would be to promote insulin release from those beta cells. Now, it's the main mechanism of the disease is insulin resistance, but the theory behind these drugs is that if we can make more insulin, potentially that incremental increase in the amount of insulin that we're triggering may actually lead to the end organs responding the way they should. So drugs like glipizide, exenatide, sitagliptin, really their basic mechanism of action is to promote insulin release. Now they each have unique specific mechanisms, but the kind of underlying 20,000 foot level mechanism here is to promote more insulin release, and hopefully that leads to improved glucose uptake by the body tissues. Side effect wise, glipizide is associated with hypoglycemia, exenatide is associated with pancreatitis, and sitagliptin is associated with mild infections, specifically of the urinary tract and upper respiratory tract. The third major oral hypoglycemic strategy is to increase sensitivity of cells to insulin. Now, this treatment strategy really makes a lot of sense because if cells are developing resistance to insulin, if we can find a way to make them more sensitive to insulin, then we're in pretty good shape. That means we can really get insulin to do what it needs to do and get glucose to go where it needs to go. So metformin and pioglitazone, which are some of the most commonly used drugs for type 2 diabetes, are in this category. So they both really try and increase insulin sensitivity, and they have varying mechanisms, some of which are a little bit unclear, specifically related to metformin. But major side effects associated with metformin are lactic acidosis and major side effects associated with pioglitazone are damage to the liver and the heart. So just important to keep that in mind. You don't want to prescribe that drug to patients who have liver damage or have heart trouble. The final sort of oral hypoglycemic strategy is to stop the reabsorption of glucose in the proximal tubule. So after glucose gets absorbed through the intestines, goes through the bloodstream, tries to go to all of the body tissues, the legs, the arms, muscles, brain, heart, whatever. Eventually, it's going to end up in the kidneys, in the blood vessels that are supplying the kidneys, and to prevent that glucose from being filtered and then reabsorbed back into the bloodstream, canagliflozin basically stops that reabsorption process. So all of the glucose that's sitting in the blood that gets filtered into Bowman space and into the renal tubular system stays there. So obviously it's associated with glucosuria because we want glucose to be excreted. We have too much glucose in the blood, so we want to push it into the urine. But unfortunately, that also has some manifestations that are not so pleasant. So glucose is a favorite food of many bacteria that cause urinary tract infections and also fungi for yeast infections. So important side effects to be aware of with canagliflozin. Finally, later on in the disease process, we mentioned that the pancreatic beta cells can just get exhausted, and so it's important at this point to be able to supplement insulin in order to provide a basal level of glucose control in those patients. So the next discussion we're going to have is about diabetes insipidus. Now, diabetes insipidus is a little bit different than diabetes mellitus in that it's not as focused on glucose, but it is focused on water reabsorption and concentrating the urine. In diabetes insipidus, the basic problem is that we have decreased reabsorption of water in the kidneys, specifically the distal tubule and the collecting duct, and that leads to a high urine output that's made, for the most part, of water. So there's two kind of flavors of diabetes insipidus, and the first one is called central DI. Central DI is due to damage of the hypothalamus or the posterior pituitary due to trauma or infection or anything like that, and it leads to a lack of ADH production by the posterior pituitary. If we don't have any ADH, that means that we basically have too much urination and it's very, very, very dilute. We basically are excreting all of the water that's floating around in the renal tubules. Instead of taking it back in and holding onto it, we're just getting rid of all of it. So the major test that's used for diagnosis of central DI is the water deprivation test. And we talked about before, what happens when we deprive a normal individual of water? You can take a moment to think about it. Essentially what happens is we deprive an individual of water and our total body volume goes down because we're not supplying our body with water. This means that plasma osmolarity goes up. This means that water reabsorption then also goes up because we want to hold on to whatever water we've got. This means if we're increasing water reabsorption, we're also increasing urine osmolality, which is the concentration of solute in the total amount of fluid in the urine. So if we're reabsorbing water back into the blood, decreasing the amount of fluid that's in the urine, we're going to increase urine osmolality if we're depriving ourselves of water. In a patient with central DI, water deprivation does not lead to any increase in urine osmolality. That's because there's no ADH to tell the kidney that, hey, we need to hold on to this water, don't give it to the urine. The second half of that water deprivation test is to see how the kidney responds to exogenous ADH administration. So in a case where a patient has central DI, ADH administration gives you that normal increase in urine osmolality because really the problem in central DI is there's a problem with the posterior pituitary in producing ADH. So if it's not making enough ADH by itself, supplying extra ADH is going to help concentrate the urine appropriately and then normalize the water balance and normalize the amount of water that's being excreted in the urine. So treating central DI is very straightforward. All we're going to do is supplement those ADH levels with something called desmopressin, which is a analog of ADH. Obviously, we also want to keep them hydrated. We don't want to keep them losing water through urine and not staying hydrated. So hydration is also an important component. Now, the other flavor of diabetes insipidus is nephrogenic, which means that the problem, instead of it being central, instead of it being in the hypothalamus or the posterior pituitary, nephrogenic implies that the problem is actually with the kidney. And in this case, the kidney is resistant to the effects of ADH. And this can be due to congenital defects, inherited mutations, or drug exposure, like lithium or something called dimethylcycline. Nephrogenic DI also gives us excessive diluted urine, but in this case, the water deprivation test and ADH administration give you slightly different results. Again, water deprivation does not give you any increase in urine osmolality, and this is because even though we're making normal ADH, the kidney isn't responsive to it, so it doesn't know when to start holding on to water and increase that urine osmolality. In the second half of that water deprivation test, when you administer ADH, again, the problem is not with the lack of ADH, it's a problem with the kidney responding to the ADH. So administering ADH doesn't do anything to the urine osmolality, so we're continuing to lose water and not know when to start holding on to it. So treatment of nephrogenic DI, again, involves hydration, but it also involves a few other drugs called diuretics, which essentially manipulate the renal tubular system to absorb solutes in water at different points along the track. And it's a little bit beyond the scope of our discussion now, but just for your information and enrichment, essentially what we want to do is promote water reabsorption at earlier points before ADH is supposed to act, in order to basically create a temporary volume loss state that promotes the reabsorption of water and sodium to compensate. And so some of the drugs you should be aware of to treat nephrogenic DI are hydrochlorothiazides, it's a thiazide diuretic, or amiloride, which is also a diuretic that's used in these patients. And specifically, amiloride is used for lithium-induced nephrogenic DI because it blocks the absorption of lithium. Again, this is really beyond the scope of our discussion right now, but for completeness sake and for your own knowledge's sake, it's here for you. So now going back to our learning objectives, to summarize, we talked about the roles of insulin, talked about glucagon, talked about ADH and their major functions with respect to the kidneys. We talked about the filtration system and how glucose kind of goes through that system. It gets filtered, it gets reabsorbed up until a point at which it can't be reabsorbed anymore, and that leads to diabetes mellitus. We talked about the urinary concentration and dilution system, specifically related to ADH and diabetes insipidus. We either are not producing ADH or we're not responding to ADH, but it leads to excessive dilution of the urine because we don't know when to hold on to that water. We talked about the differences between diabetes mellitus and diabetes insipidus based on pathophysiology. Again, diabetes mellitus has to do with a hyperglycemic state, whether it's due to lack of production of insulin or lack of responsiveness to insulin, whereas diabetes insipidus, instead of talking about insulin, we're talking about a lack of production of ADH or a lack of responsiveness to ADH. And we talked briefly about treatment options for each of the subtypes. Obviously, type 1 diabetes, we want to supplement and replace insulin. Type 2, we talked about the oral hypoglycemics. Central DI, we talked about replacing ADH, just like we talked about replacing insulin in type 1 diabetes. And in nephrogenic DI, we talked about some of the diuretics that can be used to manipulate the renal tubular system to essentially normalize the water balance and normalize the urine concentration and dilution systems. So that's the end of this podcast. I really hope that you got a lot out of this. And again, if you have any questions at all, please don't hesitate to ask. And I'm looking forward to our small group session on diabetes that's coming up shortly. Thanks.